Alright, so today we're going to go over a voiceover of the foot and ankle PowerPoint. We're basically getting into the lower extremity now after doing the upper extremity, so you'll see a lot of similarities between the two. To start, we have 26 bones in each foot, for a total of 52 between the 2 feet. You have 5 metatarsals, 14 phalanges, and 7 tarsal bones. So what you should notice is that the difference between the hand and the foot is the difference to 1 bone, because you have 8 carpal bones, but you only have 7 tarsal bones here. So these, very similar to the hand, 5 are distal, 5 proximal, and 4 intermediate or middle phalanges. The big toe is considered the first phalanx. So as we count these off, we count them off just like the hand. So the first toe will be number 1, 2, 3, 4, and the pinky will be the 5th digit on there. Orientation, lateral will be the 5th toe side here. So your lateral area will be always on the pinky side of the foot. The medial side will be the greater toe, which is on the first side here. The first toe is also known as the hallux or great toe. Either one of those terms to describe this whole digit is fine. Spaces between the metatarsals and phalanges are known as the MTP joints. So instead of CP, you have MTP, which will be these joints right here. The metatarsals being these, and then you'll have your phalanges at the distal portions of those. We also have the DIP and PIP joint spaces. Those are exactly the same as in the hand. So the DIP joint spaces are going to be on the distal phalanxes in between the intermediate and distal phalanxes on there. Your proximal interphalangeal joint spaces will be these spaces between your proximal and intermediate phalanges, going all the way down through here. So the big toe only has 2 phalanges. You only have 1 interphalangeal joint space. It's neither a DIP or a PIP. It's just an IP joint. Mobility type, diarthrodial, means it's freely movable through the foot, so you can move it around in a lot of different directions. The TMT joint spaces are going to be between the tarsal bones and the metatarsals going across on here. So those will just be right at the bases of these bones going across. Posterior bones, mid and hind foot are made up of 7 tarsal bones. So the mid to hind foot will be this area right through here. So these bones are all listed up. The biggest will be the calcaneus or the heel bone. It doesn't look quite as big from this perspective, but the calcaneus is the largest tarsal bone. The navicular bone, as in with the wrist, has a very similar shape. So it's going to be on the medial side, kind of going in this kind of arch going around. 3 cuneiform bones, all next to each other. Those are going to articulate with the first, the second, and the third metatarsals. So what you have is you have the first, the second, and the third cuneiform. You can use your terms as well, medial, intermediate, and lateral cuneiform as well. Talus, this is the bone that articulates with the tibia. This is going to be the most superior bone here. It's a little bit different shape than everything else. And then the cuboid is going to be a lateral portion. It's going to be shaped just like a cube, going to the outside here, just proximal to the base of the 5th metatarsal. Anatomy listed, as we mentioned, 1, 2, and 3 with the cuneiforms here. This is just a side view here. You're going to see the medial cuneiform, the navicular, and then the talus. We talked about this is going to articulate with the tibia, and then the calcaneus or heel bone out towards the most posterior edge of it. You have 3 different arches of this. You have a medial, a lateral, and a transverse arch. So the medial, just viewed from this particular side when you're looking at the first toe. The lateral, if you're looking at from the cuboid side or the lateral edge, you would see here. Transverse arch, you're going to have this portion right here on most patients, some a little bit flatter than others, but this is more of a different plane looking at it from front to back. Facets and calcaneus joints. So facets is basically where these areas would touch between 2 bones here. So you'll have some different joint spaces here. You'll have a posterior, middle, and anterior facet. This is just the heel bone in profile here. So posterior, obviously the most posterior, middle, anterior is going to be more towards the front, towards the toes. Joint space here, talocalcaneal joint space. So as these 2 bones kind of join together, they form this space between the talus and the calcaneus. Anatomy projections, so the AP is going to be a dorsoplantar. That means it's going to the dorsum side, exiting towards the plantar or the bottom portion of the foot. Typically, with our laterals, we will do them medial-lateral, but in certain cases when you're doing weight bearing, it will be lateral-medial in terms of the projection. Movements. Most of you know these movements already from the last chapter. When you flex your foot up, you're using dorsiflexion. Plantar flexions, when just going the opposite way. Inversion, eversions, where you're actually flexing the ankle in and out. We'll talk a little bit more about those special views coming up. Start with, first view is going to be your AP view of the foot. Plantar side is going to be down. This is going to be at 40 inches. We're going to do a 10-degree angle to the heel. I'm not going to really expect you to adjust to 2 inches down to give you 38-inch SID. I think we'll just stick with 40 inches for this. This is going to be done tabletop, so the foot will be on top of the IR. Small focal spot. We do want to see the small, fine fractures within the phalanges and sometimes the metatarsals. Side to side, you just need to include the first through the fifth toes. So you can get this edge here all the way to this edge on here. Usually the widest point is going to be the great toe right around the metatarsal phalangeal head up in here. Top to bottom, include the tip of the longest bone to about the malleoli. So usually it's the first toe, sometimes it's the second toe. You want to get down to the malleoli, which are these little edge parts of the tibia and the fibula towards the outside. Central ray is basically going to be the base of the third MTP joint. So we're looking at the third metatarsal. Base of the third metatarsal, it doesn't really make sense. It says MTP because that would be right here. We're actually going to center down here, so that should just say MT joint base. 50-2 is what you're going to start at. You're going to have a lot of overlap through this area here, so you can trim off a little bit of the back. If your light field goes past the heel, you'll probably open a little bit too much in your collimation. Visually what it looks like, so be stepping right on the middle of the plate, marker towards the outside. There's always room because of the way the foot is tapered to put your marker right in this area right through here. And if you want to keep it lateral, that's fine. Just keep it on this side of the foot. Sandbags can sometimes be placed because people with poor muscle control here will actually push this cassette out and their foot will actually move as you're trying to get a nice solid AP view on that. So you can put some sandbags, just make sure they do not overlap the image. The next view, the AP oblique. So this is going to be a medial oblique. So what we're going to do is we're going to turn the knee towards the inside. All this is going to be remaining the same. Lateral portion of the foot up approximately 40 to 45 degrees. I think the book says 30. But typically you are going to do this in a true oblique, some 40 to 45 degrees. CR, base of the third MT joint. Top to bottom include the longest toe and all of the heel. So whichever toe is the longest, get all the way from there, all the way down to the heel. So you want to see the entire calcaneus down towards the bottom of the image. Area of interest is going to be the base of the fifth metatarsal. There are certainly other areas, but this is the main area of interest here. This is where the most common site of fractures will be. Usually throws one sesamoid bone away from the head of the first metatarsal. So typically you have two sesamoid bones. You have one here and one right next to it. On an AP view, which we'll go back to here, you can see the two sesamoid bones here and here. They're usually going to be paired off. So when we get to here, now the medial one is going to slide over to where the lateral sesamoid bone was, and the lateral sesamoid bone is going to slide over to the joint space in between the first and the second toe. Marker, still a good spot to put it on through here. This is going to open up the joint spaces a little bit better through the tarsal bones. It's going to separate the bases from 3 through 5 very clearly, and it'll also show you the sinus tarsi, which is this little open area right through here. You can use a sponge, as is shown here. Most patients can hold it on their own though, just by bending their knee and then just rolling their hips to the inside. So it shows up a little bit more of the anatomy on here. So make sure you go through this anatomy. You should be able to answer everything on here. Some of the test questions will be from this. This shows a little fracture going across on here. So as you see this fracture going across side to side, that's typically a break. If you see it going lengthwise, that is usually a growth plate if you happen to be looking at a kid. So don't be confused by a fracture that's going side to side like this as opposed to going vertically on that. Let's see. Here, joint spaces, sinus tarsi, visualize, kick out the heel to align better. So as you roll your foot to the inside, you want to slide or kick your heel out a little bit just to maintain this line straight up and down. So you're going and a nice aligned film instead of kind of going off to the edge like this particular image looks. Lateral foot, same thing, 40 inches tabletop. Medial lateral projection, bend at the ankle to form a 90-degree angle. So there should be some dorsiflexion through the ankle here. This one does not have dorsiflexion. Neither does this here. It's just going to align it a little bit better. CR, base of the third metatarsal. Increase your technique a little bit more since you're going through more bones. You're going through all 5 bones now instead of just through 1 bone. So you should notice that your collimation is going to start to go up a little bit as you go from your AP to your medial oblique to your lateral. Collimation should run along the bottom of the foot because your foot is flat down at the bottom. This creates a nice straight line going across on here. Just make sure you get a little bit of the tibia and the fibula going across on here. You maybe need a little bit of inch going across. Toe to heel is what you're going to collimate from front to back. So don't be too concerned about staying on the third metatarsal. You want to make sure that you get the entire foot from front to back on there. Parts of the foot, it's really quickly, since we only have 4 minutes here. The forefoot is going to be everything from the metatarsals forward. Midfoot, these bones right in here, including the cuboid, cuneiforms, and navicular. Hindfoot is just going to include 2 things, calcaneus and the talus. Just going to show you a little bit more anatomy. Lisfranc's joint going across here. Chopard's joint going across the back on here. They're going to look for those as reference lines to make sure the foot's not broken or out of place. It's a less common lateral medial foot. You don't see that often. You can do an external oblique foot. That's really going to open up the navicular more than anything else, but this view is rarely done as part of the normal series. Weight-bearing feet, done mostly for podiatry, but you will be doing those. In this case, you would be shooting a lateral medial projection because you're coming towards the outside of the foot instead of the inside. Moving on to the ankle, we're going to have 40 inch. Our AP ankle is going to be 40 inches, tabletop, small focal. You can use an 8x10 cassette. Make sure you dorsiflex the foot at 90 degrees because that'll open up this space a little bit more. You want the entire talus to 1/3 of the tib fib. So we are going to center a little bit higher than what Merrill's talks about. Merrill's talks about centering through the joint space, but if you do that, you're going to get a hole out of this area right through here, which is pretty much useless. So consult either with Jill or myself about where the proper centering is and what it should look like. Side to side, just make sure you got both malleoli. That's this portion here and this portion here. CR above the joint space approximately 3 to 4 inches. Mortise view. This is an internal rotation, but it's not a full internal rotation. This is only going to be about 15 to 20 degrees. We're going to rotate the foot internally because we want to open up this mortise joint space here. So you should be able to see this entire joint space here without any superimposition. So this is a type of internal oblique, but not a true internal oblique. This is what it's going to be explained anatomically. So as you look at it, it's going to sit at this angle. So if you put your fingers on both malleoli, you're going to turn the foot in until it is going right through the middle of that joint space. External view, not done quite as commonly, but you're just going to externally rotate it about 45 degrees at the outside. This one shows a lot of fractures, but basically you're going to see the heel a little bit in profile. You're going to see the fibula overlap the tibia more towards the medial side now. Rotated about 30 degrees, not 45 degrees. Lateral ankle, same almost as the lateral foot. So you want to make sure that it is on its side. It is a medial lateral projection. Just going to focus on getting the base of the foot to the heel, and then the same amount of the tib fib that we talked about. So centering about 3 to 4 inches above the space. There's some miscellaneous fractures you can go through. Other ankle views. This is a true internal oblique with a 45-degree angle. Usually this is too much for most departments on there. If you do it and your mortise isn't open, you just need to back off the angle just a little bit. Inversion, eversion, these are just stress tests just to see if the lateral ligaments are torn. The medial ligaments can also be seen when we do this. This is just having a tech actually force the foot towards the outside while holding it in an AP position. Harris view, this is the heel. This is a 35 to 40 degree angle going proximally. This is going to just kind of lengthen out the heel as you see here. So make sure you kind of go over this anatomy. You should see the talocalcaneal joint space pretty well on this. Lateral heel, just like the lateral foot and ankle, just collimate it down. Spurs, most common sight. This concludes it. You can look through these as much as you want.